In this video, I want to spend more time talking about the extra time fees. So based on my field work, I think you can expect that 20 to 25% of your visits, you will have lots of questions that the patient asks you, or maybe even occasionally a lot of questions that you need to ask to get a really good history. So an example would be the patient's had 3 different procedures at 3 different facilities, and they've been on 5 different meds for some problem, and it takes you a long time to sort out what happened before the patient got to you. So these extra codes, I'm going to go through all of them. So one of them could be had a discussion about advanced directives or other sort of end-of-life issues. Next one could be the extra time it took to treat an acute disease. So classic example there would be someone who came in with an asthma attack and you give them the nebulizer treatment and that sort of thing. So of course, this is not the total elapsed time. This is the little pieces of time it took you to actually go in and reassess the patient and tell the nurse or whoever, to give another treatment or not, that sort of a thing. Because the assumption is that you'll keep seeing other patients while this patient's in a room getting this intense treatment. I think the extra time box is the best place to talk about family or friend concerns that aren't about the patient directly. So this doesn't happen very often, but the patient might say, hey, my aunt has cancer and I want to ask you about that. So just however long it took you to answer that, then this would be how you document that. Could be an unusually long history. The example of the lots of previous treatments and so forth would be a good one for that. And then this is the one I think you'll probably use more than any. It's the unusually long shared decision making. So that is where the patient has complex issues that they need addressed, and there's lots of options on acute treatment, long-term treatment, quality of life, quantity of life, all these judgment calls we have to make where it really does take some time to explain to the patient their options and so that the patient can make the best decision for them. You can also charge for filling out forms. You can charge for looking up the next best diagnostic or treatment option. The spirit of this is not for patients to pay you for continuing medical education. The spirit of this is if you would have referred a patient because you tried a treatment and it didn't work, and so you say, okay, well, I'll send you to the whatever other doctor. But instead you say, you know what, let me take a minute, go look something up, and then you come away with a good evidence-based answer of if the preferred treatment didn't work, what's next, and you save the patient another trip to see another doctor for the same problem, then that really is a value-added use of your time, and I think you deserve to be paid for that. If the patient gave you a big stack of medical records and expected you to look through all of them, then you should be paid for the time it takes to do that. These next two are the other places where there's some counseling time. So the caveat with the sort of lifestyle counseling and mental health counseling is that basically there are other professionals, dietitians, nutritionists, psychologists, whatnot, that do a wonderful job with this, and I really don't think that's the best use of your time. But I also recognize that patients will sometimes ask you for this, and so this gives you a place to document that time, but the caveat is that the payment rate is less for this. It's more commensurate with what a dietitian or psychologist would make. And then finally, this just gives you another place. So let's say, you called up or patient called you and you talked about something and said, you know what, I really need to see it, come on in. And so this is a place where instead of generating 2 separate bills, you could just sort of lump them together in one bill after they come to the office and see you. So the other just sort of reminder is that the time expectation. So brief is up to 2 minutes of both taking the history and then negotiating the plan. moderate 4, thorough 6. So if you spent, let's say, 15 minutes taking the history and then talking about the plan with the patient of all their diagnostic options, treatment options, that sort of thing, then that was a thorough assessment of their chest pain or whatever the symptom was. And so that would be basically 15 minutes total, so that would be 9 minutes of extra time on top of the thorough assessment. So that's the spirit of how this is intended to be used.